Okay, so we will move on to Dr. Sumanto Mukhopadhay right now, who is the consultant in structural interventional cardiology in St. Bartholomew's Hospital, largest cardiology unit in UK. He has extensive experience in structural intervention, including TAVI, mitral and tricuspid edge-to-edge repair, valve implants, complex GUCH intervention, and is also a proctor for many of the technologies. He is the principal investigator in multiple international trials. So over to Dr. Sumanto Mukhopadhay right now.
Thank you. Thank you for the kind words and the introduction. And I would like to thank the organizers of the symposium to invite me to speak on this topic of tricuspid regurgitation. Let me share my slides. So can you share my slides? See my slides?
Yeah, we can. Oh, we can.
So as we know, tricuspid regurgitation is an important but yet quite underappreciated entity in cardiology practice, with a prevalence around 8 to 35% in the patients that walk into a cardiologic unit. In the United States, the prevalence of more than moderate tricuspid regurgitation is estimated to be around 1.6 million, which is far exceeding the estimated patients that are being surgically treated today. In patients where we will undergo structural valve intervention, we have seen that more than 70% of the patients who have an edge-to-edge repair of the mitral valve still continue to have more than moderate tricuspid regurgitation at even 2 years of follow-up. Similarly, in patients undergoing TAVI for native aortic stenosis, the prevalence of more than moderate tricuspid regurgitation is around 11 to 26%, depending on various institutional data. Now, tricuspid regurgitation, as we know, portends very poor outcomes, which is not limited to right heart failure and organ damage, such as renal or liver failure. Also, it is implicated that it is a marker of poor prognosis in patients with reduced ejection fraction. So in this study published by Ben-Fari et al., it was shown that with increasing rates of functional tricuspid regurgitation, the survivals diminished up till 10 years, irrespective of the left ventricular ejection fraction, as well as irrespective of RV function and pulmonary hypertension. Thus, we can agree that tricuspid regurgitation is a very common incidence and is quite prognostic, but still there is a reluctance in the referral of these patients, or we seem to undertreat these kind of patients. The reasons that we have analyzed for this is, one is a delayed diagnosis of tricuspid regurgitation. Second, the varied etiology of the disease process, varied morphology of the tricuspid valve that imposes challenge on treatment, and also the predominant mode of intervention till now, which was surgery, had very poor outcomes with an in-hospital mortality more than 10%. And still we have evolving evidence but reduced awareness about the transcatheter options to treat tricuspid regurgitation. Now, in terms of presentation, these patients can have a very varied presentation and can land up in any clinic, right from the GP to a hepatologist or even a nephrologist, and of course to us cardiologists. The predominant symptoms that they present with could be very non-specific, like fatigue, reduced exercise tolerance, peripheral edema, worsening renal function, or even problems like ascites, portal hypertension. And sometimes, which is not very frequent, unfortunately, they were detected with a systolic murmur, dyspnea, or atrial fibrillation, and thus being referred to as cardiologists. Thus, there is a very need of the day is to create awareness regarding tricuspid regurgitation, its prevalence, and its early detection. Once diagnosed, we follow a particular protocol where we take them through the diagnostic assessment and clinical assessment with echocardiogram, CMR, or CT, depending on the etiology and cardiac function. A right heart catheterization and a coronary angiogram is also quite pertinent to management of these patients. So as a regular cardiologist, even if we are not a valve specialist, we should focus on optimization of these patients as soon as they are being referred to us, with intensifying their diuretic regimen, proper rate and rhythm control, referring them for revascularization or treating of their LV or left-sided heart valvular function with TAVI or TEER, and also providing proper treatment for the pulmonary hypertension. Now, we should ask for referral for these patients or create an awareness if they have particularly a TR which is severe in grade or more, or have a complex pathology, or have had recurrent decompensations or heart failures. These patients should be referred to a specialist for evaluation of transcatheter or surgical treatment. Now, as most of us will be aware that in the TR grading severity as compared to other valvular lesions, it has been reclassified into severe, massive, and torrential based on the vena contracta width, effective regurgitant orifice area, or regurgitant volume. But the basis for this is mostly the patients with severe or more should have an early referral rather than just intensifying the diuretics, because if we sit on them long, then their RV goes off, the disease progresses, and our outcomes with any intervention or surgery is worse. Now, when we talk about the varied etiologies, we know predominantly tricuspid regurgitation is secondary, that is to left heart disease or pulmonary hypertension or heart failure, and very little percentage, 15%, is predominantly a disease of the leaflets. However, again, this etiology has been reclassified with regards to the kind of interventional treatment that we can offer. Mostly the changes with the etiology classification that has been introduced is the secondary tricuspid regurgitation has been divided into ventricular and atrial secondary. The reason being that edge-to-edge repair versus annuloplasty, where we can apply this, and also with regards to the prognosis, with early studies suggesting that ventricular secondary tricuspid regurgitation has a worse prognosis than atrial secondary, which is just due to RA or tricuspid annulus dilatation. The other important thing that this classification introduced or highlighted, this was there, but it was more highlighted, was a reed-related tricuspid regurgitation, as a significant number of our patients we know have a cardiac device in situ. So whether that lead is causative or incidental is quite important to the type of intervention that we choose, particularly with regards to orthotropic valve implantation at the tricuspid position versus a edge-to-edge repair. And it's been divided into a causative, where the lead itself is causing impingement, perforation, or adhesion to the leaflets, versus the lead is just coincidental with severe tricuspid regurgitation. So we need to take into consideration of the etiology, what is the best way, whether we continue on medical optimization or refer them for an early intervention. Now, the other challenge that the tricuspid valve poses is varied morphology. And here we see that this is a nice depiction by Rebecca Hahn and their group about the morphology of the tricuspid valve. And we can understand that if the morphology can be so varied, definitely we have to have different options to treat it. Only edge-to-edge repair might not be sufficient, though it is in most of the cases, as we see that the most common type is the type 1 with 3 leaflet morphology, the usual tricuspid valve morphology. Type 3, where there is 4 leaflets, mostly due to an indentation of either of the leaflets, and among which type 3B, where there is splitting of the posterior leaflet, is more common. Now, why is the other reason, or why tricuspid regurgitation is still undertreated, is that the guidelines also are not in favor of treating tricuspid regurgitation, as the surgical guidelines, both European and American, give class 1 recommendation to treat tricuspid regurgitation only if they are undergoing a left-sided heart valve surgery or a left-sided surgery, with European guidelines also incorporating severe symptomatic primary TR, but without severe RV dysfunction. But as we know, a lot of these patients have had previous left heart surgery and now have presented later on in next 2, 5, 10 years with severe tricuspid regurgitation. They do not find a good place in our guidelines yet. Thus, there is a need for additional options apart from surgery. And also, we know that from the previous studies that surgical risks are pretty high with an in-hospital mortality of 10%. This is another recent score that was developed for prediction of mortality in hospital after tricuspid valve surgery. And here we see that if the tri-score is more than 4, then the risk of in-hospital mortality increases exponentially, thus making most of the patients in our daily practice very high risk for surgery. And therein comes the role of the percutaneous treatments, which at present in our armamentarium, we have edge-to-edge repair with TriClip or Pascal, or an annuloplasty with Cardioband, Millipede, or orthotropic valve replacements, particularly in the tricuspid position with Evoke coming out with good data, Lux valve, and also we have conventional valve and valve therapy with the TAVI valves been putting in previous valves or rings, and heterotropic cable valve implantation techniques like trick valve or Tricento. Now, as the options increase, that's why we have to look at various morphologies and various considerations to analyze which is the right treatment for the right patient. And these are the various things that we look as a structural interventionist to decide which valve option should we give to the patients. And of these, the most important would be the leaflet tethering, leaflet morphology, coaptation gap. Also, we need to consider what the RV dimensions are. Another important thing is a TEE imaging of these patients, whether we have a good images or not, whether we can get the additional information from intracardiac echo, which we use significantly at our center in patients with not so good images to get the desired treatment. Now, this is a table summarizing the various trials or the various data we have on different percutaneous options. I would say overall from this, we understand that there is a high rate of procedural success with all of these technologies, with edge-to-edge repair being the best still now, as we have more data on it. And also there has been significant reduction of tricuspid regurgitation with almost all of the therapies with improvement in functional class. And the most important is that these procedures are pretty quick and have extremely low adverse events related to the procedure, and the safety profile is really good. So these are a couple of quick examples that we have done. So this was one of the patients with severe tricuspid regurgitation, absolutely surgical turndown, where we used edge-to-edge repair therapy, reducing the tricuspid regurgitation to mild to minimal. This is another option where we treat the patients with previous surgical tricuspid valve implantation or ring, where we have used a normal TAVI valve, Sapien, and to correct the regurgitation. This procedure, again, is a very quick procedure, 15 to 20 minutes, low risk, extremely successful, and can be done under local anesthesia as almost like a day case procedure in our unit. Similarly, the other option is patients where the gap, coaptation gap, is very big, and also having leads restricting in this patient, it was the posterior leaflet which was restricted by the lead, and edge-to-edge therapy was not deemed suitable. Evoke is an option whereby we implant a new tricuspid valve. This was another patient where he had history of previous CABG with cardiorenal cardiohepatic syndrome, CT not suitable for implantation of a valve in the tricuspid position. However, we implanted a trick valve, which is 2 valves in IVC and SVC, thus alleviating the symptoms and improving his renal and hepatic condition. Thus, this is the algorithm that has been currently been almost followed, not in toto, but regarding offering of percutaneous treatments, where we see the primary ones, if there is a good morphology, we would go into edge-to-edge repair. However, if the leaflet quality is poor, then we might think of tricuspid valve implantation. Secondary, again, we have got a whole array depending on the leaflet quality versus if the patient is really in an advanced disease state, late presentation with poor RV function and quite bad renal and liver functions, then they are usually put on a conservative treatment or versus considered a heterotropic caval valve implantation. So in summary, I would say that despite its high prevalence and poor prognosis, still most of the patients, more than 90%, are not treated adequately for their tricuspid regurgitation. Early diagnosis and referral to a valve specialist along with the heart failure specialist is key to managing tricuspid regurgitation properly, and a multidisciplinary team approach should be taken for percutaneous tricuspid intervention, as this is instrumental for having good patient outcomes. Thank you.